Good. Oh. Can anyone who's logged in online confirm they can hear us okay? Can you hear us? Yes, great. Okay. All right, guys. Thanks for coming, everyone. We have food that's on its way. They deliver this somewhere else in the hospital. They're packing it up and bringing it back. So please, do not be shy, as we've done before. Get up in the middle of everyone's talk. Get in front of people. Put your elbows out. Get your butts in, and go get your food because we want everyone to eat. And if you're hungry, it's going to be, you're not going to work as well. So please get some grub. Again, we want to thank Lottie for all the work she does for this conference. So it's and Lottie can tell us about the CME changes through AHAC are upon us.
Yeah, so if some of you all have been attending other conferences throughout the hospital, you may have noticed starting now, instead of signing in, there'll be a QR code available at the beginning of the conference. 5 minutes once the conference opens. For the people that attend via WebEx, we'll drop it in the chat. It's a link. All you do is click on the link and you'll get awarded your CME credit that way. You have 30 minutes after the conference ends to still log in to get the credit. But once the link and the 30 minutes go away, there's no way to get credit. So no emailing me saying, hey, I was there, please sign me in. That's all over with. So I will put the QR code at the sign-in sheet and maybe bring a couple of them in here on the tables. You can just log in that way to retrieve your credit. The other thing is, in order for this to work properly, you have to have a WakeMed account. So if you don't have an account, I have a paper out there to show you how to sign up to get one. If you do have an account, maybe go on and test it or make sure you know the login and see that you're already receiving credits. If you have credits missing, please email me directly and I'll help you work through it and navigate through that. Any questions? Talk to me out there. Everybody online heard that?
Any questions, guys? It's a big change.
It's a big change. It's hopefully more efficient, and let's work for all parties involved.
All right, so today we're going to do something a little bit different, and we're going to move at a healthy clip. I'm not sure how this is going to work out with time, but we're going to talk about some key or seminal papers in critical care that are new from the past 1 to 2 years. So the leadership team from this conference, including Brandon Schoonover, Amanda Edwards, and Trevor Taylor, are going to be presenting papers as well. And the papers were sent out earlier for you all to review if you wanted to. And we're going to review this in a quasi, we're going to start with the case to make it clinically relevant. These are all real cases from WakeMed. And we're going to use those papers to help answer a clinical question. We are also going to review, as you have to do for these critical care trials, review their design and how they were run so that you can support the conclusion that you're going to make for this clinical question. So as part of that, we will be digging into a little bit of the study design, but we're also going to be cognizant of time. And so we want to try to get about 5 minutes of conversation in a discussion for each of these trials. And so that means we're going to move at a healthy clip. You could take each one of these trials alone and talk about it for an hour and all of its pros and cons. So this first one we're going to start with is Mr. Jones. He's a 58-year-old man with coronary disease, diabetes, BMI of 48. He's admitted to the surgery ICU following emergency sigmoidectomy with end colostomy for perforated diverticulitis. And unfortunately, the patient aspirated on induction. It's now post-op day 1. And I'm rounding on this patient. I go and see him. He's intubated. He's sedated. He's got severe ARDS by criteria. Plateau pressure is exactly 30. He's on a norepinephrine infusion at a relatively high rate. He's oliguric with a creatinine of 2.6, and he has a documented normal creatinine at baseline. And he's already 10 liters up and is requiring ongoing resuscitation. And Trevor's going to talk about how much fluid to give septic patients. There's a trial covering that too. That's a whole nother discussion. This patient's nice and positive. They're already starting to get a little puffy. Their lungs are looking wet, and they're on Zosyn. And so one of the questions we're going to talk about is when you might want to initiate renal replacement therapy for these patients. Actually, I'll come back to that too. And so, when you go in and look at these patients, they're going to keep getting multiple liters of fluid for at least the next 12 or 24 hours until this kind of sepsis resolves. This patient already has ARDS. You want their lungs dry. And you can see what's the writing's on the wall. Their kidneys are failing, and you know where they're going. And so the question is, well, can I get ahead of all this and start CRT? Can I get ahead of all this and start CRT to get rid of the bad humors in the patient's blood? These bad humors of the septic shock from the perforated colon. Can we get that fluid off, get them in a better fluid balance, help them in the long term overall, but also to immediately help their lungs? And that's something that, you know, it's a real question that you know, we often have. And so this study is one that attempted to answer it. It's the START AKI trial. And this is the answers before we even go into all the details. This is a nice infographic. It's a open label RCT, multiple hospitals, multiple countries. And what they looked at was standard strategy for CRT in terms of when it starts versus an accelerated strategy within 12 hours of the patient meeting criteria. And if you guys look at the screen here, what you'll find is that mortality was no different. That was their main question. That dependence on CRT was actually worse, or excuse me, dependence on dialysis, no kidney recovery, was actually worse in the group that had accelerated CRT, and that adverse events were greater in the group that went on early. So we're going to come back to all that. And so that is our clinical question. Should I throw this guy on dialysis early as opposed to later? So about 2/3 of all patients in the ICU have AKI. We see it all the time, right? So you think about vents, you think about the kidneys. They're the two most common things. And the rationale for starting dialysis includes, like I said, this fluid balance and these bad humors. But you might want to delay it because you got to put a line in. It's heavy in terms of resource utilization. And we also don't really know who's going to go on to need dialysis or not. We are 4 judges of that. And so while I'm assuming this guy is going to need dialysis, his AKI may have already peaked. And so putting him on dialysis may be for nothing. And so this has been studied a whole bunch, going back to 2002. And all these are big trials that were in the big journals, randomized control trials, that looked at when to start renal replacement therapy in sick ICU patients. And the only one that was associated with any change in mortality was the Elaine trial, which was actually a surgical cohort of patients. That's the only one. And I want you to know, too, this trial we're about to talk about here, the enrollment of this trial is greater than all of these trials combined. So this was why we're talking about it, because it's a big one. So as I mentioned, 15 countries, 168 sites. They did their power calculations and came out with about 3,000 folks who needed to account for attrition. And again, this is a huge sample size. Other pre-specified subgroups that they wanted to evaluate were, did outcomes change based on patient sex, prior kidney function, whether they're surgical patients or not, where they're at in the world, septic patients, and then based on their SAP score in terms of how sick they were. So they had to be greater than 18 years old. They had to have some degree of kidney dysfunction, specifically KDIGO stage 2 or 3. And then the unique thing about this study, which is I think quite powerful when we look at these big trials in terms of how they apply to us and whether or not we can use them, is that the providers had to confirm clinical equipoise, meaning that they had to affirm that going on early versus going on late, that they had no, the judgment was that either of those approaches were both reasonable. If they felt that that patient actually really had an indication for dialysis and needed to go on earlier, that they could not claim clinical equipoise and therefore not enroll the patient in the study. And again, this is a reminder of the criteria for AKI: increase in serum creatinine greater than 0.3 within 48 hours, or increase in baseline of greater than 1.5 times in the past 7 days, or urine volume less than 0.5 mLs per kg per hour for 6 hours. Then you have your different stages. Now, importantly, exclusion, specifically people who may really need to be on dialysis. So if their K was greater than 5.5 or bicarb particularly low, or they had a drug overdose, or they had any renal replacement therapy in the last 2 months, or kidney transplant, or they came in with poor GFR to start, less than 20, or any of these things, bad things with the kidneys here, those patients were not included in this study. So they tried to keep it kind of clean in the sense that these people, either their problems with their kidneys already, or they really need to be on dialysis already. And so that's where that clinical equipoise comes in, because you already removed the people that needed dialysis right away. So you had these accelerated arm, again, 1,400 people and 1,400, that's a lot. And 96.8, essentially all of them in the accelerated arm received renal replacement therapy within 12 hours. On average, that started at 6 hours after they were enrolled in the study. Their average creatinine was 3.3 and fluid balance 2.7 liters. I'm gonna jump ahead down here in the later group, 3.27 versus 4.3 in terms of their creatinine, and a fluid balance of 2.7 versus 5.8 in the later group. Now, the control group, they came on to dialysis if they had a persistent AKI with an increase in their creatinine, and they either had an increase in their K, a decrease in their pH, a farther decrease in their bicarb, or they were determined clinically to be fluid overloaded, or their AKI persisted for more than 3 days. So that's for the trigger to put the late group on dialysis. But again, no obligation to start. This is based on the judgment of the attending. So only 62% went on to receive dialysis. All right. And 70%, this is for both groups, 70% were on CRT, 25% were on intermittent dialysis, and a small portion were on SLED. So what did we find? So no difference in 90-day mortality. Again, we're talking mortality. It's a very black and white measure. This is what these large ICU studies are usually studying, and it can be very, very difficult to detect the change in mortality. In this study, did not. Secondary outcomes, I listed the secondary outcomes with a significant difference. Interestingly, the patients, again, that went on mostly CRT or HD early had a lower chance of recovery in terms of their kidneys. It's really interesting. 10.4 versus 6%, that's a pretty decent difference. The accelerated group also had a shorter ICU length of stays by 1 day, so 9 versus 2 days. And we talked about these pre-specified groups the study leaders had looked at before they even started the trial. They said, we want to look at surgery patients. Are they different than medicine patients? We want to look at septic patients. Are they different than non-septic patients? No, not in this, with these results. And they also found that adverse events were more common in the group that went on dialysis early, specifically hypotension, for instance, 23 versus 16.5%. So the authors concluded that in critically ill patients with severe acute kidney injury, an accelerated strategy for the initiation of renal replacement therapy did not result in a lower mortality at 90 days when compared to standard treatment. And the standard treatment was pretty close to what we actually practice as if you really look at what we do in the ICU on a daily basis. So this was a pragmatic design. Again, providers had to declare clinical equipoise. There were meaningful outcomes here, specifically mortality. And there's a clear difference between the groups. So the group that went on later had way higher creatinine, and they had a higher total fluid balance. And this is widely applicable to us because this was multiple ICUs across multiple countries. So it wasn't one institution. Weaknesses are pretty slim. This is kind of like a masterclass on how to do a huge clinical trial. It's very clean design. It's a good question as well. And so there's not a ton to really knock on when it comes to this trial. And so the bottom line that we take away is there's no benefit to starting renal replacement therapy. This also supports essentially all the prior studies, randomized controlled trials except one. So if you're looking at that patient and saying, gosh, I just want to jump on, let's get ahead of this. And let's get that CRT started early, you're not actually helping that patient. And in fact, you may be harming them by decreasing their likelihood of renal recovery. Looks like food is here too, so you guys don't hesitate. This is not for review right now, it's a lot of stuff, but this is a nice diagram that shows those different studies. You can see all the acronyms here. And what their early criterion was, late criterion, and then their outcomes. So it's a nice little summary. So we come back to our case, and this gentleman, he should not be put on dialysis until he has true indications, AEIOU type indications, to be put on it. Gosh, it's only 12:15 already. I'm fast. All right, any thoughts, really quick? Dr. Biswas.
You think in the end you concluded saying that the Uh, One was there was no difference, and then it would not help to start early. Any input about the wait days? You mentioned something about earlier discharge from the ICU. Certainly the volume is one other thing other than the potassium and the creatinine or the renal function.
Yeah. So Dr. Biswas asked about
that earlier extubation, earlier out of the ICU, even though the mortality 90 days and survival did not change.
Yeah, so Dr. Biswas asked about lower vent days, potentially in the group that went on renal replacement therapy early. And I'm pretty sure, because I looked in the supplement for this, is that the answer is no, they did not have a significant difference in ventilator days. But I'll look that back up, but almost certain it's no.
And then did you mention a little bit about them ending up on the dialysis longer? That's a little interesting that we found that. Even though, do you think the hypertension that some of these people, we do notice that if you dialyze them, they end up with lower maps and then having to give volume and all. Do you think that plays significantly, or how do we explain them that if you start it early and you stop it in good time, how is it that they end up on dialysis more often than people who eventually need it?
Yeah, so the question was, why does the group that got started earlier have decreased renal recovery? We don't know the answer. That's an association identified with the study. We don't know the causation of it. One of the complications that was higher in the group that went on dialysis earlier was hypotension. We know that episodes of hypotension can lead to kidney injury. So that's one of the thoughts that could apply to it. But the bottom line is we don't know the exact mechanism.
So yeah, it's an ongoing battle oftentimes we have with the renal service. And once they get on dialysis, even in a standard patient, this is early versus late, that how much volume to take off. But sometimes it's that you're chasing pills there. In some of those patients, we end up with hypertension. And then we're either increasing the vasopressors or giving some more volume. Often we try to take the lead at that and see that they don't take too much fluid off. Because that's certainly something that's been difficult oftentimes during dialysis.
Yeah, I agree. And I already think I've come to the conclusion if we do this again, when we do this again, that we'll do less papers so we can have more time for discussion. But this is good. Again, even if anything else, it's good exposure to these trials, even as you last through.
Thank you. All right, so we'll jump right into our second trial. I'm going to be going over the MENS 2 trial. So this is our case, Ms. Delusions. She's a 72-year-old female with hypertension, type 2 diabetes. It's uncontrolled, complicated by neuropathy, osteoarthritis. She was hospitalized in the last year following a mechanical fall. She sustained a hip fracture at that time, requiring ORIF. Her daughter details some difficulty with the patient's recovery, mainly a lot of delirium during her inpatient and rehab stay. She's not returned to her baseline level of function. She's actually living with her daughter and granddaughter now. Everyone in the house was sick over the holidays and recovered except Miss Delusions. She is short of breath at rest. She has a productive cough, pleuritic chest pain, and hasn't slept in 2 days due to all that coughing and pain. She's diagnosed with community-acquired pneumonia, has one admission, failed high flow nasal cannula and required mechanical ventilation. She's also diagnosed with septic shock, one admission, lactate of 4, some end organ dysfunction and creatinine 2. Sepsis protocol is complete, vancomycin and requiring chemotherapy. So our clinical question here is, in critically ill patients and those at high risk for delirium with sepsis and respiratory failure requiring mechanical ventilation, does dexmedetomidine provide any clinical benefit over propofol? If we know this patient is likely to be delirious throughout their stay, is there anything we can do to help prevent that? So this brings us to the MENS 2 trial. This occurred was published in 2021 by Hughes et al. You'll notice Wes Ely on there as well. The background on this, in order for us to talk about MENS 2, let's talk about MENS 1. That trial occurred in 2007, and the use of dexmedetomidine infusion resulted in more days alive without delirium or coma, and more time at the targeted level of sedation than with a lorazepam infusion. Thus, we have a change in culture and practice, and we get rid of benzos a lot from our units. So we have many other trials that we could talk about. But that brings us to the Pain, Agitation, and Delirium Guideline of 2013 and the PADIS Guidelines of 2018, which emphasize propofol or dexmedetomidine over benzos, and then light versus deep sedation in critically ill mechanically ventilated patients. And as we all know, ABCDEF bundle compliance. A little more background. Propofol, as we know, is a GABA agonist. Benzos are too. Dexmedetomidine is an alpha-2 receptor agonist, and it has some potential to help in sepsis. It has anti-inflammatory and bacterial clearance properties, reduces neuronal apoptosis, and promotes biomimetic sleep. It's more similar than propofol to a regular sleep. The MENS trial in particular noted a more pronounced 28-day mortality reduction in the dexmedetomidine group versus lorazepam group in a subset of patients, the sepsis patients. So that brings us to this clinical question of MENS2, which compares dex to propofol in the septic mechanically ventilated population. So here's a little bit more about the design. It was a multi-center, double-blind, randomized controlled trial, 13 medical centers. They were only in the US though. And this was a while ago. These studies, participants were enrolled 2013 to 2018. So between the PAD guidelines and the PADIS guidelines. They screened over 4,000 patients and 432 were randomized. We'll talk about that a little bit more when we get to weaknesses. But the primary endpoint they were looking at was the number of calendar days alive without delirium during that 14-day intervention period. The secondary endpoints that they looked at were ventilator-free days at 28 days, mortality at 90 days, and then global cognition at 6 months. What I liked about this study is it answered the initial clinical question, but that was a short-term outcome. And their study is detailed enough that it also is evaluating our long-term outcomes here. So the inclusion criteria, you had to be greater than 18 years of age, you had to be admitted to a medical or surgical ICU with suspected or known infection, and treated with continuous sedation for invasive mechanical ventilation. Lots of exclusions here. Baseline severe cognitive impairment, pregnant or breastfeeding, blind, deaf, or unable to understand approved languages. If the center didn't have an interpreter available to do that 6-month cognition screening in their language, then they were excluded. Second degree or third degree heart block or persistent bradycardia, any allergies to the study drugs, if they had an ongoing indication for benzos or were on this previously, anticipated to have an immediate discontinuation of mechanical ventilation. Expected to be on neuromuscular Velcade for more than 48 hours if they were in more moribund state, or if they received mechanical ventilation for more than 96 hours before meeting inclusion criteria. So the groups. We've got arm 1, which is the DEX group, 214 patients, a range of 0.15 to 1.5 micrograms per kilogram per hour. The RAS targets were mostly 0 to -2. PROC was the 208 patient group, weight-based again, 5 to 50. And the common management here was that they had opaque coverings of the bag and tubing trying to hide what propofol looks like. Protocolized titration every 10 minutes, light sedation targets, 0 to -2. They have a very extensive protocolized rescue protocol for pain and agitation, which really focused on heavy doses of opioids, which we know are deliriogenic as well. There was also midazolam available in there for rescue, which is confounding as well. All centers reinforced the ABCDE bundle as well. Before I get to the outcomes, also when they were enrolling individuals in these groups, someone comes in, they're intubated, the researchers would then obtain consent for the study from both the providers involved and patient family. So within that 24-hour period, those people were consented, but during that 24-hour period, they were already probably receiving propofol to start. They were randomized and then potentially switched to the other agent. So the outcomes, no difference in number of days alive without delirium or coma over the 14-day intervention period. Again, all of these outcomes are going to give dexmedetomidine first and propofol second, so 10.7 to 10.8 days. Secondary outcomes, no significant difference in ventilator days at 28 days, no significant difference at death at 90 days, no significant difference in global cognition at 6 months. Those are very flat. This was definitely a negative study here in comparison. And no difference among baseline characteristics in either arms. So the author's conclusions: among critically ill adults with sepsis who are requiring mechanical ventilation and for whom recommended light sedation approaches were used, dexmedetomidine did not lead to better outcomes than propofol with respect to days alive without acute brain dysfunction, ventilator-free days, death at 90 days, or cognition at 6 months. So we can talk about a few strengths here. Multi-center randomized controlled trial. It had the bones of a good study. It was a well-designed study. Delirium is complex, particularly delirium in mechanically ventilated populations. You're dealing with multiple confounding variables here. One of the things that I really like to see here was the adherence to the ABCDE bundle. Spontaneous waking trial, 98%, spontaneous breathing trial, 93 and 95. You can read all of those, but definitely adhere to the bundle. And the endpoints emphasize both short and long-term outcomes. But it had some inherent weaknesses. Inadvertent unblinding, that propofol, or they were able to see that it was propofol or Precedex 14% of the time, unfortunately. Over 90% of eligible patients were excluded, and that was believed to be due to physician or relatives declining participation. That's a huge number of patients that were excluded, and I'm not really sure what to think about that. And this led to slow enrollment over years. The trial drug doses were also relatively low. Lots of opioids on top of that, and there were frequent needs for rescue doses of sedative or analgesic agents. The bottom line, despite theoretical pharmacological benefit in patients with sepsis, dexmedetomidine does not improve delirium outcomes, mortality, vent days when compared to propofol in adults requiring mechanical ventilation. I like this image here, a bunch of crossroads and crosswalks, conflicting signals. We thought Dex may provide some benefit in the septic mechanically ventilated population, but we're going to stay on a current traffic pattern and continue with our ordering restrictions, propofol first line, and transition to Dex available for SAT failures. And that's what we did for Miss Delusions. Just a couple of things, questions that we sometimes receive. Dex previously was 10 times the cost of propofol. It is currently 1.5 to 2 times the cost of propofol now that it's generic. And you will likely see a lot of niche trials utilizing Dex for agitation and delirium management in the future. A few on the horizon really relate to more dementia and post-operative delirium management, not necessarily the mechanically ventilated population. Can stop there. Any questions, guys?
This is OC. My question is this: given the number of patients in this trial, obviously this trial couldn't address the issue of the risk of propofol infusion syndrome. So is there any change in our recommendations regarding duration of therapy with propofol, or should this somehow bias us to feel unconcerned about the risk of propofol infusion syndrome?
It's a very good point. I will add that one of the things about this study was actually the median duration on mechanical ventilation or with sedation, and the median time was actually only 3 days. So I'm not sure we would have reached that level in this study.
I think with that, you mentioned 90% of patients being excluded with long enrollment time and with a relatively short ventilator time makes it difficult to ascertain the true meaning of these results or apply them.
Any other questions? With that, I'm just going to put in one plug. For those of you that participated in our critical care conference in years past prior to COVID, we're not quite bringing that back yet, but we are proud to host the Carolina, Virginia chapter of SCCM. Our conference will be coming to WakeMed and be in the Andrews Center June 8th and 9th. So this is just to save the date for any of you that might be interested in seeing me or participating. More information about registration will be forthcoming.
We'll send an email out to a short order of that so you guys can get on your schedule. It'd be great to have a good show here.
Okay, moving right along. So, can't work at a trauma center without having some sort of violent trauma in the case. So here it is. We'll start off with a 56-year-old male who presented initially as a self-inflicted gunshot wounds to the chest. He has a past medical history of depression, alcohol abuse, diabetes, and high blood pressure. He was initially a GCS of 13 at the time of arrival, was tachycardic and hypotensive. He had an obvious gunshot wound to the chest, right there in what we consider the box area. MTP was initiated. He had a left chest tube placed emergently on time of presentation. He had, with frank blood being evacuated at that time. He was also appropriately lined up in the trauma bay and went emergently to the operating room where they performed a left thoracotomy, left pericardial window, non-anatomic resection of the left upper lobe and left lower lobe, along with an X-flap as the patient, despite adequate resuscitation, was becoming more hemodynamically unstable. And so they opted to go into his belly to see if there was anything there that they might have missed, which was negative. He went to the ICU post-operatively, and where he did fairly well. He was able to be extubated on post-trauma day 2, and was able to actually be transferred from the unit on post-trauma day number 4. The day that he got transferred from the unit, he sat there, waved at us, and said, "Thank you for everything that we have done." Later on that night, early the next morning, the patient was asked his bedside nurses if he could go to the bedside commode where they were working on getting him up. He was sitting at the edge of the bed and then randomly started to void while sitting at the edge of the bed with a blank stare. And there was some question if he had seizure activity or not. The patient's color then changed. He became hypoxic, was blue, and then went into PEA arrest, where he received CPR for approximately 23 minutes with thoracoscopy being achieved at that time. Patient was transferred back to the ICU, where he did not regain any neurological function. The family at that point opted to transition to comfort measures where the patient was able to donate, where CCGR was obviously called, and was able to donate his kidneys. While this was not an out-of-hospital arrest, our team did talk amongst ourselves if cooling would have been appropriate for this patient or not. Historically, we do not tend to cool trauma patients. I believe it's one of the contraindications to the WakeMed policy for TTM. So therefore, with that said, we looked some to see if there were any studies looking at inpatient cardiac arrest and cooling, and there are none to very limited studies. So the article that I'm about to present, we are extrapolating a little bit since it is out-of-hospital cardiac arrest and cooling management. So therefore, the clinical question is, in patients who are unconscious following out-of-hospital cardiac arrest, does targeted hypothermia compared with targeted normothermia impact all-cause mortality? Just a little bit of background. Currently, as we are all aware, the international guidelines, AHA guidelines, they do recommend targeted temperature management to prevent hypoxic ischemic brain damage. They've looked at three different trials mainly, the ACA trial and the Bernard trial, both done in 2002. Those trials, however, they had very low ends. Their sample sizes, as you can see, there are 137, 77 respectively. And the number of patients in the control group did develop fever. So the question at that point was, were the benefits from hypothermia or was it from avoidance of fever? The TTM study, they had a little bit more people enrolled in that study where they looked at cooling people to 33 degrees Celsius versus 36 degrees Celsius from out-of-hospital cardiac arrest from a presumed cardiac cause, and they showed that there was no difference from mortality. Hyperionum trial, they had, done in 2019, they had roughly close to 600, I think it was like 583 patients enrolled, where they looked at non-shockable cardiac arrest. And they showed at 90 days that the moderate hypothermia group compared to the targeted normal hypothermia group actually had improved favorable neurological outcomes. And so at that point, in 2021, the European Resuscitation Council said, hey, let's go ahead. We're going to recommend cooling people between 32 and 36 degrees for a minimum of 24 hours and avoid fever for at least 72 hours following ROS. So they're kind of taking all those trials and came up with their guidelines. So therefore, we looked at this article of hypothermia versus normothermia after out-of-hospital cardiac arrest. The design was an international investigator-initiated superiority trial. They did randomize everybody on a 1-to-1 ratio at time of presentation to the emergency department. They're randomized between hypothermia and normothermia. The patients were also co-enrolled in the TAME trial at the time, which is where they're looking at targeted mild hypercapnia, allowing patients to be a little bit hypercapnic was beneficial. The healthcare providers that were providing the care to the patients, they were not blinded to this study for obvious reasons, because we all know everything that can go on with cooling patients. However, the people that were blinded were the people that were performing the neurological prognosis and doing functional outcome in the study administrators. They looked at the 30 days, 6 months, and 24 months for the outcome, with the primary outcome being death of any cause at 6 months. Secondary outcome is poor functional outcomes at 6 months as a primary, which is defined as a score of 4 to 6 on the modified Rankin scale. And you guys can see there how that scale works. Then the outcome assessment was done either by face-to-face interview or telephone interview. This study did coincide with COVID, and so they had to go to the more telephonic reassessment. And then the power calculation, they wanted to enroll about 1,900 patients, which they were able to do. However, 37 of those patients had consent either not being able to obtain or withdrew, and 2 of them were randomized twice. And so that gave them number of patients of 1,800, and it's actually 61, not 62. I apologize about that. And with a power of 90% to detect a relative reduction of 15% in the risk of death in the hypothermia group. So inclusion criteria, you had to be greater than 18 years of age. You had to be admitted to the hospital after an out-of-hospital cardiac arrest of a presumed cardiac or unknown cause. They had to be unconscious at time of presentations, unable to obey verbal commands and no verbal response to pain. And they had to have had ROSC for at least 20 consecutive minutes, or they had to have 20 consecutive minutes of spontaneous circulation following ROSC. Exclusion criteria, they had to be assessed 3 hours or within 3 hours of ROSC being achieved. They could not, their initial rhythm could not be asystole. Their temperature at time of admission had to be greater than 30 degrees Celsius, not less than. They had to be on ECMO, or they could not be on ECMO, they could not be pregnant, they could not have a suspected intracranial bleed or severe COPD with long-term home oxygen being used. So out of that, they screened 4,355 patients, 55% not randomized due to exclusion criteria, so 1,900 were randomized. As I said before, 39 patients withdrew consent, and then 2 were randomized twice. So they were not included in the trial. So therefore, they had 930 patients, or 1,861, 930 of them in the hypothermia arm and 931 in the normothermia arm. At that point, they were able to evaluate 1,850 patients, were evaluated for survival, as 11 of them were lost to follow-up. In the hypothermia arm, they looked at targeted temperature of 33 degrees Celsius, which was achieved through rapid cooling, either by cold fluids or physical cooling devices, i.e. surface, ice bags, or intravascular. They placed a bladder probe to maintain the target temperature, and then they started rewarming at the 28-hour mark by increasing the temperature by no more than 0.3 degrees Celsius per hour for a total intervention period of 40 hours. So that's what they're looking at, was 40 hours. The normothermia arm, what they did there was they used pharmacologic and conservative therapies to maintain a temperature of 37.5 degrees Celsius or less. If it got up to 37.8 degrees Celsius, then they were placed on either surface or intravascular cooling devices as well to try to bring the temperature back down to a normothermic range. Common management of both groups after the 40-hour mark, so from the 40 to 72-hour mark, they were normothermic. Sedation was mandated. Now, what sedation was used, that was up to the treatment teams, but sedation was mandated up to 40 hours. There was a stepwise protocol that was used for shivering, And then, like I said, a blinded clinician performed a neurological examination at 96 hours. So here are the outcomes. So what the outcome shows, 6-month all-cause mortality, it was 50% in the hypothermia group and 48% in the normothermia group. So really no statistically significant difference in mortality between the two groups. And even looking at the main secondary outcomes, they were about the same as well. What was interesting was the serious adverse effects. They had obviously more arrhythmia and hemodynamic instability in the hypothermia group compared to the normothermia group. Everything else was the same across the board. So just that graph put out in words. So the author's conclusions that patients that underwent induced hypothermia, they did not have a lower mortality rate compared to those that did not undergo induced hypothermia, and functional outcome did not improve from hypothermia either. The strengths of this article were that it was a large randomized trial. It was an international trial. Everybody was blinded minus the treatment team. There was also clear separation between the groups. It was either you're getting cooled or you're not getting cooled. They had less than 1% missing data on mortality, so follow-up was relatively good, unlike, obviously with the article Amanda just presented where 91% of their patients were excluded. Majority of the patients that they screened were included and were follow-up and were able to be followed. And then they also had protocols carried to minimize variability. The weaknesses of this of the study is one of the big ones, or the biggest one, is that temperature goal is reached 3 hours after randomization. So the question then begs, is earlier cooling more beneficial? That's something that is going to be really hard to look at, and I don't know that will ever be able to be looked at for a variety of different reasons of just cooling in the field. And then also only looked at out-of-hospital cardiac arrest. So this does not really help the management of in-hospital cardiac arresting. So the bottom line, in my opinion, that the data does not support doing targeted temperature management in an out-of-hospital cardiac arrest, and that further studies do need to be done to further assess normothermia versus non-targeted temperature management. So it's just important to make sure that they don't get febrile. Not necessarily that we have to do them. And then still need a study if cooling of in-hospital cardiac arrest patients is beneficial.
Range on their temperatures, was it 32 to 36?
I think it was 33 to 36 is what they were going for.
I know Trevor had presented some of this information on our guideline here. How does this study fit in? If you refresh us, how does this study fit in with WakeMed's?
So I think I think the trend is that in the near future we will be moving away from actually cooling patients and just keeping in line with this normothermia goal. I think historically there were some metrics for whether or not patients were cooled as to how that improved outcomes, but I think as we move away from that, I think that we will be moving more in line with this, getting away from cooling and just doing strict fever avoidance. It seems like less is more, the more we know that fever is bad, but I don't think that anyone is as convinced that cooling is good.
And so, Brandon, then for protocolization, or I guess what do you think about using protocols or guidelines to avoid fevers as opposed to inducing hypothermia?
I think that is, as Dr. Taylor was saying, a good way to go. And one of the main reasons for that is, one, we all love protocols. Protocols, they should be at least easy to follow, and it's a stepwise fashion. Everybody's on the same page. Then also you can, at that point, encompass more patient population where you don't have to limit it to just medical patients. You can, at that point, start looking at more of the trauma population, which suffers, as we all know, car crashes sometimes, what came first? Did the heart attack, did the heart attack or the MI/cardiac arrest come first, and that led to the car crash, or vice versa? So at that point, you can start standardizing it across more of the population.
Brandon, I have a question. So in the context of protocolized fever management, suppression of shivering during topical cooling is a very important component of this. Are there studies out there to give us guidelines as far as best practice goes?
I did not look to see if there are studies out there. I'm happy to do that and get back to you, Dr. Deckwood. I'm sure that there are. I'm not aware of them.
That's the voice of God. All right, again, we're going to keep moving, guys. Limited discussion, unfortunately, for each paper, but we can change that. Yeah.
Alrighty, thanks for hanging in there. We've got our last talk today. Any questions, please feel free to raise a hand. I like that technique. All right, so here's our clinical case. We have Miss Smith. She's an 84-year-old female. She presented to the emergency department from her skilled nursing facility. She's altered and she's hypotensive. You can see she's tachycardic with a heart rate of 116, hypotensive. She's tachypnic and mildly hypoxic. And then looking at her labs, we can see she has a leukocytosis and anemia. She also has a developing AKI there, and then a metabolic acidosis with lactic acid of 4.2. Her urinalysis is suggestive of infection. Using conversational care, we'll tell her your blood pressure is low. We will administer fluid, the purpose of which is to raise your blood pressure. And so then we ask ourselves this question, how much fluid do we give her? So in sepsis-induced hypotension, does aggressive fluid repletion improve mortality? That's the question we hope to answer today. I wanted to take a step back. We have a wide range of different types of providers in this room. So why do patients with sepsis become hypotensive? What is sepsis? These are things that we read in charts all the time, but developing an understanding of this can help us in the care of these patients. Historically, the definition of sepsis was in part guided by the SIRS, or systemic inflammatory response syndrome. These are patients who are either hyper or hypothermic, tachycardic, tachypnic, and have an elevated white blood cell count. And you would historically have had to have two of these. Now, the difference between this, someone who is septic, and someone who's just done exercise at the gym or come into the emergency department as a trauma without any evidence of infection, is the fact that we believe that these people were ill. This was historical, though, got updated in 2016 by our new Sepsis 3 guidelines. And what we've started to do now is really define sepsis as a process whereby we see it as involving life-threatening organ dysfunction that's caused by a dysregulated host response to infection. And it's now being viewed more as a syndrome, and we use that term to remind ourselves that it is really an isolated thing that can have various manifestations. In and of itself, it's not necessarily a disease process, but it is a result of something else. Before she was dancing with Freddie Prinze Jr., Robin Cook was doing this commercial from 1997. I don't know if anyone remembers this, smashing an egg. And she says, "This is your brain on drugs." And this is my version. This is your body on sepsis, okay? So what is happening here? Why do we become hypotensive when we have sepsis? So we go back to the case of Miss Jones there. She has her urinary tract infection. Bacteria have seeped into her bloodstream. How does her body become aware of that? So it happens in a variety of ways. There are something called PAMPs, P-A-M-P-S. You can make your own jokes. It stands for pathogen-associated molecular patterns, okay? So these are different types of normally surface-bound proteins that are common between different types of bacteria. So in gram-negative bacteria, we have something called lipopolysaccharide, LPS. This is similar to say all of us have noses. Our noses are different. The LPS of E. coli is different than LPS of Klebsiella, but if you're looking for LPS, you'll find it. On the gram-positive side, we have lipoteichoic acid, LTA. Similar feature. It is a commonality that bacteria have across the species, regardless of the different subtype that the body can identify. It identifies it with 4 different mechanisms. So on the cell surface here, we have toll-like receptors. We also have C-type lectin receptors. For bacteria that have moved intracellular, we have nucleotide binding oligomerization domain type receptors. And then we also have retinoic acid inducible gene 1 type receptors. Okay, so 4 different ways the body can recognize it has infection. When the immune system becomes revved up, our leukocytes or white blood cells go out on the hunt. Complement becomes activated. Complement is the part of the immune system that we call the innate immune system. It functions independent of antibody production. Our coagulation cascade becomes altered and messed up. And then we also have necrotic cell death that serves through DAMPs, not PAMPs, damage associated molecular patterns, okay? That goes back and tells the cell, hey, there's a problem. So I think about this, the part of the movie, the astronauts are walking through, they see the alien slime, and all of a sudden they're saying, hey, something is probably wrong here. So the cells are unaware there's a problem until they see the dead parts of their old friends floating by. And they say, okay, something is wrong here. We need to get on our game. We mentioned before that the coagulation cascade becomes impaired. And so one thing that happens in sepsis is that we have this chronic activation and microthrombus formation. So out in our tiny little blood vessels, we're getting clot forms. That's because coagulation is activated. And then we also have impairment in fibrinolysis as well as our anticoagulation mechanisms. So we are not able to clear the clots as well as we normally are. When that happens, we have impaired concentrations of activated protein C, so it is low. There were historical studies where we tried to give people activated protein C. It didn't work. And we have an impaired ratio of activated protein C and thrombin. That causes an abnormal balance up here with our sphingosine 1 phosphate 1 receptor compared to our sphingosine 1 phosphate 3 receptor. For those at home, we're looking on the top right part of that picture there. We then see that that causes problems down below with our vascular endothelial cadherins and our tight junctions. These are the parts that normally hold our blood vessel cells in close approximation so that fluid can't leak out. So these things become destroyed as the downstream result of these microthrombi formation. We see cell death and shrinkage. We see capillary leak, interstitial edema, and hypotension. So this is why the patients that we care with, who we care for who have sepsis, are hypotensive, okay? So that was tiny science. Let's come out of the weeds a little bit here and go back to our question. So why would we want to give a patient with sepsis-induced hypotension aggressive fluid, right? That's sort of the underlying part of this question that we're not seeing. In large part, we've previously been told that aggressive fluid repletion will improve mortality in these patients. So this is one of the sort of overarching papers in critical care medicine. It's called the Rivers Trial, written by Manuel or Manny Rivers, published in New England Journal in 2001. The very short version is that he did everything possible to make sure that patients had a whole ton of fluid in them. He looked at their CVP. If it was low, he gave them fluid. If they were still low with their MAP, he gave them vasopressors. If they still weren't perfusing, he gave them blood products. Every potential mechanism whereby he could make sure that these patients were fluid replete was conducted. And he showed that there was a very significant improvement in mortality with his early goal-directed therapy versus standard therapy, okay? So that is the historical background whereby we would believe that aggressive fluid repletion would lead to a mortality improvement. So this brings us to the current trial. It's called the Early Resuscitative, or Restrictive, or Liberal Fluid Management for Sepsis-Induced Hypotension. It's by the PEDAL Network. The code name is the Clovers Trial. So the PEDAL Network has come up with several witty other trials. They had the Rose Trial, they have the Orchid Trial, now they have the Clovers Trial. And what we're trying to do is see in patients who have sepsis-induced hypotension, does giving them a lot of fluid or a little bit of fluid help? Okay, so we had two groups in this study. It's an unblinded trial at 60 US centers, so not, it is just domestic, unlike some of the ones we've talked about. Patients have already received 1 to 3 liters of fluid before they are randomized in this trial. So that's an important thing to keep in mind. And then at that point, they were split into two groups, restrictive or liberal. Definition, or the treatment schema, I should say, for restrictive fluids is really that the primary treatment is going to be vasopressors. Keeping in mind these patients have already received at least 1 liter of fluid, we're going to start to give them pressors early, and then they get rescue fluids that are allowed if they're still doing poorly. Conversely, the liberal fluid group, who's already gotten at least 1 liter and potentially 3, is getting 2 more liters, then they're getting more fluid. If they're still languishing after that, they get pressors. Here's the fancy way of saying that from the paper for those who looked at it. Our restrictive group over here, you already got fluid at the beginning. You're going to come in, you're going to get pressors. You do poorly, you get more pressors. You do poorly, then you can get fluid. In our liberal group, you've already gotten fluid. You're enrolled in this group, you get a 2-liter bolus right off the bat. You do poorly, you get more fluid after that. You do poorly, then you're allowed to get pressors down here. All right, so who is in this? Patients with sepsis-induced hypotension, obviously. You had to be an adult. You had to have suspected or confirmed infection. And you already had to have gotten that 1 liter of fluid that we talked about. Folks who were not in it were people who had waited over 4 hours since they met the criteria. Patients who'd been in the emergency department, in the hospital for over 24 hours, or patients who'd already received greater than 3 liters of fluid, including via EMS. The take-home point here is that these are patients who are coming into the emergency department relatively fresh with sepsis hypotension. They're not patients who've been languishing up on 6A for days, okay? Those patients were excluded. They thought that all-cause mortality before discharge home by day 90 would be lower in the restrictive fluid group than in the liberal fluid group. So here's what they found, all their outcomes. They did not find that to be the case. This was a negative study. So there was no significant difference in death before discharge by day 90 between the two groups. Also notable, there was no significant difference in ventilator use days here, line number 3 on the chart for those at home. Vasopressor use, those things were all relatively the same. So there was no true, real positive outcome at all for this study. They concluded that despite separation between the two groups with respect to the amount of fluid administered, as well as the amount of vasopressors, they did not detect that mortality benefit that we talked about. There were several strengths. So this is patients who came into the emergency department with a primary diagnosis of sepsis. So it's patients that we see quite often. It's generalizable. They took all comers into their trial with the exclusion criteria that I said. It's a pragmatic study, so they did not bother with blinding, with putting opaque coverings on tubes. They just took you as you were. And then they looked at a true meaningful clinical outcome, whether or not the patients were living or dying. There were some weaknesses, so they comment on this, but they don't do a subgroup analysis. So 12% of the patients in the study had CHF, 5% had ESRD. They don't comment on chronic lung disease. But one thing that I'm wondering reading this is, do the outcomes change when you're looking at these folks now, or someone who's on chronic supplemental oxygen? Do they have a different outcome? It's an unblinded study, and so they felt like there might be a tendency towards reporting adverse effects if you knew the group. So they felt like people might be more inclined to report that folks were volume overloaded if they were in the liberal group. It was a short study. It's only 24 hours, so it's rare you see something actually that short. And they had no control group, so there was no true standard of care. You were either restrictive or liberal. And the bottom line was that giving a lot of fluid didn't help make people better compared to giving a little bit of fluid, or said conversely that giving a little bit of fluid did not necessarily improve mortality, any of those other secondary outcomes we talked about, ventilator-free days, initiation of CRT, etc. Happy to take any questions.
Are they using functional hemodynamic monitoring to establish is the person dry and getting more fluid, or do they just give or not give fluid according to the protocol?
The question was whether or not there was any invasive or dynamic hemodynamic monitoring. The answer was no. So they said that that would be a great, future goal for investigation, but that's not what they commented on.
So at 24 hours, the difference between the total fluid difference, I think it was a liter.
Yeah.
Between the two groups. It's not that much, right? After the 24 hours, it's a short study. So how do you think that impacts? It's focused on that very initial.
Yeah, it's going to be hard to find a meaningful outcome if your delta is so small, I think. So 1 liter of fluid, we give people a liter of fluid of antibiotics most days and hardly even think about it. We don't even count that as like a fluid bolus. So I think it's really hard to get a true separation there. I think probably the truth is that, Buddha talks about the middle way, like that doing some fluid and pressors earlier than we're inclined is probably the best thing to be doing. I think there's probably been a hesitancy in large part due to, we have to have a central line before we can get pressors, and then you're getting a central line. I think as we move away from that paradigm, we can start doing pressors earlier, and I expect we'll see some improvement.
Hey, this is Edward. Can you hear me?
Yes, sir.
Someone's laughing already. It's probably Laurel. I love this study because, and I get on the call just so OC doesn't think he's the oldest guy on the call. So I love this because the longer you do this, the more of a therapeutic nihilist we all tend to become. And we sort of saw that with the tempering of the targeted temperature management strategies and stuff. So I know there's limitations. I thought it was a pretty substantial difference in fluid that they had gotten. I don't have this study in front of me or your slide, but I thought